Hi, welcome everybody. This is our eighth of the 14-part series, Prayojana series, Liberation of Knowledge, trying to help spread the knowledge with COVID-19. Today we have um, Basti Sukur, registered nurse, case manager, master's in healthcare leadership. She's a great deal of deep industry experience, over 30 plus, and she's been, interestingly enough, been in COVID frontline in multiple states. After working in interesting, complex areas in corporate jobs and into hospital systems, she decided to take a travel type of job to travel the country. And in the midst of this travel piece was when COVID happened. And then she was in the middle of COVID frontline in Washington, D.C. in the March, April area timeframe. Later on, she traveled to COVID frontline in Georgia. And then later on, now she's in the COVID frontline in Maryland. She's got years of experience in care management, clinical nursing, complex high-cost disease management. She has worked at Mount Sinai Hospital, Brandon Regional Hospital, other HCAA, and Florida Hospital, CareCentrix, Empire Blue Cross and Blue Shield, where we all intersect because Dr. Grossman, myself, and a few others in this company was part of Empire Blue Cross, and hence she's also has some relationship with Globex Health. And we also have Dr. Joyce Grossman, infectious disease, pediatrics, internal medicine, 3 masters, immunology, cell biology, genetics, biochemistry. She's the chief of population health for Globex Health. She's also the head of research. She's a former health plan CEO responsible for millions of lives, multiple states, medical management, complex disease manager, and she's an expert in navigation. But prior to getting into the world of health insurance, she was a clinical researcher at Rockefeller University and Cornell. We also have Dr. Adesova Okasanya, who is going to be moderating. She's a family medicine specialty in virtual care. She's been in the COVID frontline. She leads Globex Health's team in post-acute care and virtual care. And I am Juby George was I am the CEO of Globex Health and Chief Innovation Officer. Thank you for joining us. There's some disclaimers. This session is recorded. We do post it on YouTube or other medias that if we find people could use it. This is information only, not a medical advice. We continue to say that there's a lot of clinicians with different types of expertise here in the panel as providing subject matter expertise, also making comments and contributing. And none of them are acting on any medical capacity, giving medical advice. It's just informational, shared knowledge. There are some COVID-19 resources. CDC, World Health Organization, National Governors Association that you can downstream into each state that you want to, and clinical trials. Today, we're going to be going over latest on reinfection, plasma, vaccines, frontline healthcare perspective on working with COVID units from BASTE. The topics, items to be covered are introduction updates, COVID stats, frontline from BASTE, what is different now versus March and April, differences between state hospital management. So different states, since she has traveled through different states in COVID frontline, we can get a perspective on that. Reinfection, there's a case documented and from Hong Kong, not anecdotal, it's actual real case. And thank you, Dr. Halasa, for sharing that. Plasma serum, vaccine update, and some other comments. The latest on the numbers, total global cases we have as of earlier today, 23 million total cases globally, 814,000 deaths globally. Leading on the numbers are US, Brazil, India, Russia, South Africa. Interestingly enough, India still shows less number of deaths versus the total infection, which is an interesting factor. Here's some graphical version of it. You can see the United States, Brazil, India is up there, top on number of cases. It's a rolling 7-day average. This is the World Health Information at 23,800,000 deaths. We have by region, Americas 12 million, Europe 4 million, Southeast Asia 3 million, and Mediterranean 1 million. By country, US has 5 million, Brazil has 3 million, 3.6, India has 3.1, Russia has 900,000, and then we go down that. And this is something that I said Dr. Halasa will be able to speak about. Dr. Halasa, if you're on, I will put you into speaker role if he is on. Don't see Dr. Halasa yet. Okay, so this is a mortality rate. You can see that the death is higher. Deaths per population is higher. You can see that Peru, Chile, Brazil, then the US. So US is number 4 on mortality. That's significant. So you're seeing, how many people are recovering versus how many are dying. Deaths by country, 175,000 in the United States. Brazil is 114. The states that's highest COVID right now is California, Texas, Georgia, Florida, and Indiana. There's some data from China that I just wanted to say. They have a CDC, Chinese CDC. Their number of confirmed cases are very interesting, like 14 as of yesterday or today. Very low numbers. When we talk about prevention, that's better than cure. And we accept and we live in this and learn to navigate this broken healthcare system. And it is tested to the beyond its capacity. And we are seeing the cracks and we are seeing what are the problems. And part of the reason we are doing this series of webinar is to kind of help share the knowledge, help you navigate the system. Interestingly enough, the group of people that you are hearing from or the people part of GlobeX Health, we are kind of expert in navigating the system. So that's part of the reason that we are doing this, hopefully to share knowledge so that you can be a change agent. And we just have a slide that shows, COVID affects every area. And we're not sure what India is doing that's so different, but this is a Lancet document that says, there's more of a prevention methodology from the government, low-cost solution, centralized approach. They have even an app that the government created the app, they update the app, they give information through the app, sharing what needs to be done, what are the treatments or what is available, what are the diet changes you can do, and it seems to be interesting on that end. Though the death as of yesterday is 848, that is higher than the United States death. Now let's have Basti talk about, if you want Dr. Okasania or Dr. Grossman talk to Basti about her experience, or Basti share her background and experience in the COVID frontline.
Thank you, Juby. Thank you very much for having me. My name is Basti Sukur, and I am an RN, and I have been working as a travel case manager for the last year and a half. My experiences are varied, so I'm here to share my experiences and answer any questions that anybody might have as to what I've seen, what I've done. So thank you, Julie, for inviting me. So when
the precautions.
Sorry.
I mean, unless Dr. Grossman or Dr. Okasani have any questions, let's hear about the type of patients you've seen in the March-April timeframe versus now, or what is different, or what's the change.
Yeah, I think it would be great to kind of see what you've experienced first, and then we could kind of dig in about what you've experienced and what are the contrasting and and complementary things that we see like in the different areas and geographically.
Yeah,
Okay.
I think it's very interesting, you know, to hear from you how different geographic areas in the country are treating this.
Okay, so I'll do it in a kind of a chronological format. So when COVID-19 first presented itself earlier in the year, I was at Washington Hospital Center, and I was working on a medical floor, and it started trickling in that there was this virus that was doing some pretty ugly things to patients. And initially, there was all sorts of conflicting instructions as to what type of PPE you needed. Was it airborne? Was it droplet? So one hand you were being told, well, you needed to gown and glove and wear this mask. Then you were being told that, no, it's okay, you could be fine, you know, just a little paper mask would be enough. So initially there was a lot of confusion. And then as the news started coming as to, you know, the impact and how infectious it was, then they started really isolating separate units, deeming them COVID units. I only stayed a short time at Washington Hospital Center, and then I went to Georgia, and I went to Albany, Georgia, which was the hot spot at that particular time. And those little modules that you see, that COVID-19 pods, they had actually built like a mobile hospital at the hospital, and it was placed at the back of the hospital. So that was essentially for COVID-19 patients. And if you worked in that unit, you were, I mean, gowned and gloved and masked and to the max. I mean, you looked like you were in going on a space trip when you went in to take care of your patients. The treatments that I saw initially was very, people really nobody really knew what to do with the thing. And then as it started coming out, they started doing the remdesivir and that was like one of the things that they saw some results with. And right now, and I'm going to jump ahead a little bit to where I am at Southern Maryland Hospital in Maryland. There's a protocol now for when patients come in and they have either a confirmed diagnosis of COVID-19 or if they're symptomatic enough to require treatments. And it's a triad of the plasma, remdesivir, and dexamethasone. And what I've seen, and I'm going to just kind of, because I could talk for a long time about it, so I'll just concise it a little bit. What I've seen is that the patients, if they're treated early enough in their presentation, they tend to do much, much better than if you wait before you treat them. So that triad of treatment seems to be working well for patients who are treated early enough. The biggest problem that I'm seeing as a case manager from my side of it is, what do we do with the patients who come in negative, they're in the hospital for whatever reason, they test them, they turn out positive, and then the families are in fear of taking them back home? Because I think people have been given the sense that if it's almost like, and this is my own personal comparison, is that people who become COVID-19 positive, they're almost being treated like lepers, that they shouldn't be coming back home. You need to get a colony and put them. So the difficulties from my side as a case manager is, what do we do with patients who test positive and have no place to go? So, and that's kind of like my little experience.
I have a question, Bazde. Do they test these patients before they're going home to just verify that they're negative? Because that would really help.
No, they're not routinely being tested, but what they're being tested for is every time they need to have a procedure, whether it is placing a PICC line, a midline, going for endoscopy, getting a PEG tube, any little procedure you're having, you have to have a COVID-19 test. So what's happening is that the patients are coming in, right? They're not really being tested as they come in because they're asymptomatic and there's no indication to be tested. But if they need a procedure of any kind, and I'll give you a good example, somebody comes in, a diabetic patient comes in and they need to, let's say an infected wound, and they get diagnosed with osteomyelitis, and they need to go home with 4 to 6 weeks of IV antibiotics. They need a PICC line. So they're testing them before they do the PICC line, and that's when they're finding out that they're positive. So they could have come in positive. We're not just testing everybody as they walk through the door. So on the surface, it looks like they got COVID-19 in the hospital, when the reality is they might have come in with it, but they just were not tested.
No, and I agree with you, but if you have a patient who's in the hospital and now the family knows they're positive, I can understand why the family says, but now we don't want them home. We're scared. If, after, remember, they need a trial, at least like of quarantine, but once they test negative, then, I mean, the family, I'm sure, would mind taking them home and would feel comfortable.
I think the fear that has been instilled in the population as a whole about COVID, I don't think that's going to be the answer to that. And I've had this discussion with my fellow case managers, and we kind of think that if you're coming into the hospital, you need to be, I'm going to be admitted, you need to be tested the day you come in to get your baseline, because this is turning into a massive problem, because I've got patients sitting on my floor that I can't discharge because I have nowhere to send them.
Yeah, I agree. That's why, and I know it's a problem, but that's why I think if a protocol was set up and it's not just your hospital, that when patients are being sent back, that they're negative so that everybody knows they're safe. I mean, that's what they do with the baseball players.
Well, yeah. I mean, I think it's a little challenging, and I'm invested. I'm sure you understand this too. It's the challenging thing about this virus is that it doesn't turn negative quickly. So I think that has been the issue. And at least in the initial time during my experience with COVID, we had a hard time placing, because, all the facilities were like, well, we want them negative. And we're like, okay, but it takes actually a couple of weeks. For people to
I agree with you. Yes.
Yeah. So it's really kind of, it's really, of course, from a case management standpoint, it's almost kind of like, it's such a bottleneck that why were we waiting for these people to become, especially, and they could be actually asymptomatic at this point. They usually, by the time I've had anyone to place, they've gone through the worst of the virus, and now they're better, but they're still positive.
Mm-hmm.
Yep. And they could very well be placed, but of course the facilities were very hesitant, at least initially. And then we kind of put up protocols for the facilities, and the facilities started taking the patients, even though they were positive. So that was something that at least changed out here.
Okay, and well, as long as
sorry, go ahead, Dr. Grossman.
Yeah, I was going to say that as long as there are protocols that these patients get placed, right. It's not in the best interest of a patient to sit in a hospital. We know it's a hotbed of other infections. So right. That's why you want to get them out.
Right. And I'll tell you, the problem is not placing them in facilities. The discharge problems I have is sending people back home, because if they have no rehab needs, you can't send them to a facility.
Right. Absolutely.
And that's where my problem is occurring, because I've got people who are walkie-talkies and I cannot discharge them because the families are saying, no, they cannot come home. I call the hotels that the DC and Maryland have in place for patients to go if they COVID-19 positive and have nowhere to go, but they're for homeless people. So they're not taking people who have a home because their families don't want them to come home. So I've got no place to send them. And well, interestingly enough, when I was in Georgia, I had one girl who tested positive in March, and she was in the hospital for 4 months because she never tested negative. Every time they tested her for 4 months, she was positive.
Oh, that's very unfortunate.
Who's paying that bill, Beth? Oh my God.
Well, I mean, I have, you know, and coming in, I have a couple of questions here, and I have one question from William Robertson here, and he's saying, would rapid testing be able to address this huge influx of asymptomatic carriers? I think widespread testing probably would be an asset to us. And of course, we've had a lot of barriers to widely testing, based on the availability of the test versus the sheer, the sheer amount of time and effort and protocol that would need to be kind of embarked to doing that. But I do think it would probably be one of the best things for us to do. I mean, Dr. Grossman, what are your...
Yeah, oh, no, I definitely agree. If we could get rapid testing, that would help. I mean, the problem really is it takes so long to get the testing back. So everything's backlogged.
Right. There's so many factors, because, I mean, when you have the rapid test, it is rapid. And I in a couple of hospitals I've been, you have the test within a couple of hours, and that's been great. However, it's the availability of these tests that have been the issue, because, for instance, just the other week when I was rounding at one hospital, they ran out of the rapid test. So, you can understand that what a problem that was, because now the protocol is everyone who needs to be admitted has to be tested. And now we didn't have the rapid test, so now we had to kind of sequester all these patients that were waiting for their test to come back into another corner of the hospital. So again, it does cause a lot of issues for sure.
I'm sorry, and the hospitals that I have looked at that actually have the rapid testing, they're guarding them zealously because they're using them for placing patients. When you've got a bed, when somebody's saying to you, I have a bed for this patient, but I need a negative rapid test, then you're using them. Or if somebody needs to have the procedure done and they need to have it to facilitate their discharge. Right. So they're judiciously using the rapid test. So I don't see how widespread rapid testing is going to become something that we could actually do. Logistically, it's going to be almost impossible to do.
Well, at the present time, yes, but remember, a lot of other tests like influenza rapid tests, when it first came out was, sort of rationed. I think that as they become more widespread, hopefully they'll be more easily available, and that hopefully will help.
Right.
Yeah, but we're a long ways off from that, I think.
Yeah. Well, I think definitely there's, I think there's probably economic component to it, and it's just really an availability component. I feel once we've kind of overcome those, I mean, it would be like the flu rapid testing at some point, I believe. But currently, of course, that we're kind of in this bottleneck. I do have somebody else who had a question here, or had a wondering statement, and it says that from Yeleni here, and he's saying, he or she, I'm not sure, sorry. I'm wondering how many places did what some other countries did and had special hotels where people were sent. And I think Base, you kind of actually alluded to that. Although granted, those hotels seem to have been more for homeless people as opposed to people who just were infected with COVID-19.
Yes, in DC and Maryland, because I had to call the number myself to try to get my patient out, and they're like, no. Does she have a home to go to? Yes, then no. This is strictly for homeless people. And I think the thought process is that you could safely go to your home, and as long as you follow the guidelines that are given, you don't use the same bathroom, you don't, you try to minimize your interaction, you stay in your room, they feel that you could safely quarantine for the time that you need to quarantine. But whether that's true or not, I don't know.
Right.
I think I heard that early on Chinese physicians found that was a critical step, that they would be able to separate people so that they weren't sending them home. And their fever clinics were like that. Like if you were suspected of having a fever and stuff, they would assess you, and then even if you weren't especially very sick, they would put you in a hotel, with the airflow regulated and that kind of thing, so that it wasn't transmitted to family members.
I mean, I think honestly, that is an ideal situation. I think my experience has been in the front line. You know, granted, I'll be honest by saying I think I hadn't had anyone who was so ballsy to say they weren't going to take their family member back. I think I mean I think they kind of all expressed concerns as to what to do, but I think a lot of times, well, let me put it this way. I think a lot of times when we had people who came in from a household, who was COVID-19 positive, the chances were that everybody else in that house was already COVID-19 positive. I mean, and so it's because it was more or less like, everyone kind of said they had a little bit of a illness here and there, and some people were more affected than others. And then one person kind of got the doozy, and that person came to the hospital. And so, and it was hard because, again, remember earlier on, we didn't have the widespread testing. And so it was almost kind of presumed, I presumed anyone who came out from a home and had COVID-19, I kind of told all the families, I'm like, you could kind of get tested, but I would almost presume that you probably already have it. Because, the fact that you had some symptoms, but then you kind of shrugged them off, because as we know, COVID-19 can have symptoms that are very, trivial. Right. So you kind of feel okay until one person kind of gets really sick and you're like, uh-oh. And then that person we find out had COVID-19.
But let's say you have a patient and in their home, either there's a vulnerable person living, let's say who's immunosuppressed or immunodeficient, or a very elderly person lives there. Do you still feel, do they still just send them to that household if it's a crowded household?
Well, the expectation is that that family would come together and figure out what they're going to do, because, there's no arrangements made to support people in the community for that type of recovery. So, a lot of times what families have been doing is that they're like, okay, the people who aren't sick will go to one family and stay. And then the people who are sick will go and stay in another house. And I think that's part of what we have to do, is just get people to do that. But there are the ones that'll tell you adamantly, I am not taking. When I was in Georgia, the same girl that stayed for 4 months, she was 28 and had, all kinds of medical things going on. The mother adamantly refused to take her home because she had the 7-year-old grandchild taken care of. And nothing could make this woman, and we couldn't physically put her in the ambulance and send her home, because the mother said, no, I'm not going to be there to take her. What are you going to do with her? So
I mean, it sounds in the face of it, it does sound quite unfortunate. But you know what, you know what, it does make me think, especially kind of hearing, okay, what we did in other countries with the hotels. And you know what, this is honestly, I think if we had some thought process with it, this is not something that was going to be so hard for us to do. I mean, we all know for the most part, at least earlier on in this pandemic, most of the hotels were empty. This was not, I mean, that probably would have been a good strategy to kind of curtail a little bit some of the spread of the virus. But, I think that's
well, the question is that why we are testing. We have to be very we have to know why we are testing. What's the purpose of the testing? It's very important, because if we are doing the antibody testing, why we're doing it, if we're doing the saliva testing, why we're doing it. I mean, we have to, from now, we have to consider everybody's infected. And let's say we test somebody and and he is negative, and it's a false negative for a certain reason. Are we going to treat that person that he's not infected, and so he doesn't have to need to do all the precautions that we're doing, especially covering the mouth? That's very, very, very important, because we know that most of the infections happening due to shedding from the mouth. So all the patients that they come in, they need to be wearing the mask, covering their mouth, and also the staff needs to be covering their mouth. And we assume everybody's infected by now. I mean, let's say now 20% of the whole population is infected because it's 5 million cases proven right now, around 6 million. You have to multiply it with 10 because that's how much. So that's means 60 million people. That's around 20% or less. So that's mean we need to expect that now, we need to expect everybody is being infected, and we need to treat them as they are coronavirus positive and deal with them that way. So I don't think there's a need for mass testing. I don't know what's the reason of all we have to test everybody testing. It's waste of money. I think it's if we resource that money in sending supplements and boosting the immune system for those vulnerable to improve their immune to fight infection, I think it's better than just testing mass. Or we can, if we want to do testing, it's more of measuring the herd immunity or measuring the progress of our program. That's okay, we can do it, but we can do it just randomly. Select 1,000 people from each state and find out how much people being infected. Especially, we do that with antibody testing. So just want to say, everybody, when it mention anything about testing, we need to know what's the purpose of it.
Well, I think the main purpose in at least a city like New York is to find out if you have someone who tests positive, you want to look at their contacts and test them to see whether they turn positive so they could be isolated. What at least New York City is trying to do is stop the spread. And they find hotspots that way, and therefore you could contain those hotspots. If you let everybody just mingle the way they want to, it ends up again like this huge, pandemic, because Joe Blow now is going to the Bronx and he's going to Queens. Whereas once you find out someone's positive and you test their contacts, anybody who's positive quarantines, you're really trying to stop that virus.
I think
Well,
also,
we know we're not going to stop the spreading of the virus, that's for sure. We're slowing the spreading of the virus by wearing the mask
not
and
stop it,
social
but slow it.
distancing. Yes, so we're doing it with mask, social distancing. And if you see the numbers of deaths between us and Sweden per population recently from Johns Hopkins, we are after them. So really there's not much difference. The question is that social distancing and wearing the mask will slow the spread. But if we say we're going to do testing for everybody, okay, so here's the thing. Let's say we test somebody and he is positive, right? And we isolate him. Is that mean we are really having impact on significantly on slowing the spreading of the infection? We know that everybody's going to be infected. I don't know. Why isolation? He's wearing the mask. He's doing social distancing. So what do you mean by isolation here? That's the question also. What do you mean by quarantine?
Well, I mean, quarantine, if I'm positive, then I stay in my apartment or I'm placed in a quarter of my house by myself. And, but that's unfortunately, a lot of that is called ideal, because I don't know how many people in New York have a home where they're living with other people and they have their own bathroom. And they have their own, where they really, really can isolate themselves. I mean, but that is the feeling of this, is that they isolate themselves. And once they isolate themselves, they are no longer spreading the virus to others.
I think also really to kind of think about the testing, I think also there's a compliance issue around here. The truth of the matter is that if everyone was going to be very compliant with the social distancing and wearing the mask, I think I would agree with you, Dr. Alessa. Maybe testing would be less necessary. The problem is that I'll tell you, and I've seen this, even people who we've confirmed, we tell them you have COVID-19. You know what? You see them out there, they won't be wearing masks. I mean, it's kind of ridiculous. It's like they don't believe the diagnosis. This is an education.
I don't know if they don't believe it. I mean, I live near a beach area, and they're young people. And let me tell you something, you ain't interfering with their fun. The sun's out, they're on break, they're having a good time, and let me tell you something, they walk down in front of my house in big groups, laughing and having a ball, not wearing masks. And this is the problem.
let me go ahead and repeat that again. What you say? Now, let's say you got somebody who's infected. Okay, so you say quarantine. Do you know that one is being diagnosed as being infected? There's 9 infected roaming around and recognized and tested. So as is 1% quarantining him will have an impact on slowing the COVID-19 virus. If this guy was being infected, if he's wearing the mask, okay, properly, and he has social distancing, I think it will be more effective than just isolate him. In other words, there's 9 people out there, and they are positive, and they're not isolated, but they're wearing the mask and social distancing. I think it will be similar.
You see, again, the problem is, I think it's really compliance, because I think at the end of the day, like now, when we have all these people, now we're seeing the outbreaks in the colleges, in the schools. What's the issue there? I mean, again, they're not being consistent. They're not doing the social distancing. They're not really consistently wearing the mask. And I think that's been the issue. I think if everyone was willing to be really compliant with things, yeah, I would say we could emphasize less on testing. But I think the mindset of the people out here is like, well, I don't have it. I don't need to do all these measures. And I think that's the mindset a lot of people have.
Yeah,
and
also,
as opposed to having the mindset of saying that I probably have it, I should be doing these measures.
And also remember, unfortunately, in the United States, people think it's their right. They don't want to be told to wear a mask. Right. It's my right not to wear a mask. And you see the arguing and how violent it gets. And that's part of our culture.
Yeah. I'm also curious about, I was a little struck because I work in informatics. So when that mandate came out about, now you have to report to HHS instead of CDC using.
Yeah, you're right. We're gonna get in, yes.
What is it that keeps, because the obvious solution is the hospitals get together and say, yes, we have to report to HHS, but we're also going to pool our data so that we at least know what's going on, and we have our data. Some people couldn't get access to their own data. And so that, at least we know what's happening, which is essential for us to run a hospital. And yet there seems to be this sort of lack of collaboration across many different domains, including like, why can't we get it together to get more PPE from wherever,
It's well, it's a hard one.
It's Juby. I would like to comment on, since it's asking about the data and analytics side, interoperability and the relationship and how flexible they are, each organization. If your organization is like a private entity owned by a corporation versus it's a public hospital, there are all these other factors that goes into it. And then who wants to keep their data a little more secure, not in that sense, but confidential, proprietary, a bit more, they got like this many number of COVID, that means they can just make the competition, how much money they're picking up, and what kind of government funding they can apply versus computing funding, grant. There's a lot of other factors that goes into it. The HHS, there have been almost like the initial approach to all these data sharing. So in New York, there's a tri-state, the Great New York Hospital Association and what is that? Heinous Healthcare Executives Association. They kind of share data. There's like weekly calls. They do that. But you have to understand, it took a lot of collaborative effort, and them having to deal with 9/11, Sandy, Katrina, had to learn their lessons before they get to this point of sharing. Rest of the country did not go through that kind of eye-opening experience where they already learned a lesson. This is their first time around on that kind of lesson learning. So it is going to be based on that kind of preparations that already put in place. But then leadership saying that, okay, you got to do this. This is how it needs to be done. No, I don't care about you being a private company for profit corporation versus this being state-owned entity versus that one is a nonprofit. Doesn't matter. This is what we need. Someone has to do that. And a lot of times everybody's left hanging right now. Everybody's asked to do it on their own, and that doesn't work in this kind of setting. So to be
Right.
honest, HHS they're trying to centralize. So CDC was not centralizing. It is going into a little bulk and they redistribute the data. So from what I've seen is there is a few efforts done by multiple government agencies banding together to do this. And from what I see, HHS asking for the data is actually a good thing.
Yeah, I mean, there's something going on there because the person in charge suddenly resigned and things like that. But we have, and there've been complaints by, public health people who couldn't get the data and things. But, there's also a danger of supposing, HHS says, well, you say you had 50 COVID patients and I say you had 25 and I'm paying you for 25. Or, just having control of the data is really important for, and the thing is, we have the skills, right? Informatics people know how to do this. We make big data aggregations all the time. So anyway, I was just wondering.
Change is good. The prior format was not working. Let's see what happens.
I mean, Juby, what do you think of the fact that, at least again, I go by New York City, we have networks of hospitals. So we have hospitals that are not originally from the neighborhoods they're in. Like, let's say in Brighton Beach, we have, let's say, a hospital associated with Staten Island. So therefore, it's almost like you have a war going on, and different hospitals are trying to take different territories. So they're very hesitant to share data.
So New York and several areas, the Government Office of National Healthcare IT Coordinator has already put in place, and this was prior to COVID, these regionalized information sharing networks. And it's called HIE, Health Information Exchange Networks. And it's government or nonprofit, or it is not a for-profit entity. State of New York has 8 of them. One in New York City manages all 8 of them. That's the one on the top. And every admission, every discharge, and certain other metrics has to be shared daily basis to them. They were already collecting this data. And because of COVID, they are able to expand. I don't know which area expanded to collect data, but they have good, accurate data in New York. New Jersey, from what I understand, and Globex Health is part of NJIT's health information in IT network, and that they manage the state of New Jersey's HIE, and they get every day, every hospital admission, discharge, diagnosis of discharge. If the patient had COVID, that also is inside that. So there are things like that that's already in existence that they can adapt if they know, or someone take the effort to do it. So the way I look at it, it comes back down to that territory finance thing. There's a lot of, interestingly, COVID has, nobody really wants to do it that way, but you want to keep your COVID to your place. You want to bring more COVID if you can handle them to your location so that you do get paid for it. That's one way of looking at it. There are other ways of looking at it. It's nothing isn't from a negative connotation. It's just them trying to survive as a hospital. They're all running operating in the red. Some are going bankrupt. Trying to take care of their patient population or community wherever they're based, and just surviving.
So this is a case just recently, just 3 hours ago, she died. Her age is 43, but she has an underlying diseases. So yes, those people with underlying diseases and they are positive with COVID-19, I mean, it would be nice if we boost their immune system before they get the infection. But now when they're getting the infections and they end up deteriorating and eventually into the ICU, the chance of going back is slim. But those cases who have underlying diseases, We really need to focus on them. We need to isolate them. We need to, another word, yeah, they need to be isolated, because we have to think everybody's infected now. And the vulnerable people, they are the one who need to be isolated, and they need to be treated in a way to boost their immune system so they can fight the virus. I
Well,
think
that,
that's the best way of
yeah,
isolation.
that is actually one of the agendas of Mount Sinai in their pooled hypergamma-globulin, really experiments. They are hoping to give it to people who are frontline, like military, but they also would like to see if they could boost the immune system of those who are not immunocompetent and see if they could protect them from disease. So these are the type of thought work that is going on at the present time. Hopefully the pooled, hyperimmune globulin will work, but that's being thought of.
But don't you think if you give antibodies to somebody, don't you think that will decrease his response to the virus? You got my point?
Well, I mean, I
Then you
think
cannot
that,
build antibodies anymore, right? Like, but when the mothers, when they are negative, their blood are negative, and they have to give them antibodies to suppress the immune system so they don't react with the baby
oh
positive.
yes, the ROGAM.
Right. So don't you
Yeah,
think
no.
you give
And
them
I understand
antibodies?
what you're saying, but
Right.
ROGAM, they're giving a very, very high level of antibody. And that's why basically the point is when you give ROGAM to somebody who is Rh negative, you're priming them so that when they see someone Rh positive, they're primed and they don't really see it as reactive. And so therefore they don't react to it. So it's the mechanism of the immune system that ROGAM is using. What they're hoping with the pooled gamma globulin is that you give it to patients, and now since they can't mount an immune response, you're now giving them antibodies that can mount an immune response, and therefore rather than succumbing to the virus, they overcome it. It really is the same thought work that goes on with the convalescent plasma, which does seem to work in approximately 35% of patients.
Yeah, but we're giving convalescent plasma to sick patients, like somebody
Well,
who's
no, I understand that. I mean, the
no.
thought of this is a trial to
Right.
see what happens if you give it to well patients. I mean, it's not like they're running around giving it to everybody. Mount Sinai is trying to start trials on this. I don't know if they started it, but I have read this is one of the clinical trials that they're trying to do, is to see whether or not if you do give pooled hypergamma-globulin, hyperimmune gamma globulin to immuno-incompetent people, whether it will help prevent them from getting the virus. We don't know. It's in clinical trials.
I think I mean, it's something you can go try it and all that stuff. I think it's one way of doing it. But I believe that if they have these resources and improve their immune system by using the integrative approach that we're doing and improving their endothelial function, I
Well,
think
again,
that's
if
more
you
better.
if you could prove you could do that, I think that then maybe it would be accepted. You have to realize that our medical system is a pretty closed system, and it doesn't accept everything. So if you said to them, "Wow, if I gave it, there's a some type of herb, echinacea, that I don't know the name, I'm not pronouncing it right, that does help boost the immune system." And if you gave it to all the immunocompetent people and they go, "Wow, we haven't gotten the virus," I still think the medical society as a whole would say, "We don't know. We think that's anecdotal."
Right. Now I agree with you 100%. But let's say, for
Right.
example, most of the cases that we have, they are obese. And if from now on they say, okay, everybody who has obese, they have to go through a weight loss program, we consider weight loss program as a way to protect you from COVID-19. If that will be something being in every area of education, I think that would change the lifestyle and our dieting and all that stuff. And that would kind of improve the health of the public and the fight against coronavirus. But I don't hear anybody from the mainstream educating about healthy lifestyle and treating obesity and making sure you're taking your medication for hypertension and diabetes. Make sure all that, because that helps you to fight the coronavirus. That is not there.
Well, yeah, but I mean, weight
Definitely.
loss helps diabetes and high blood pressure and cardiac disease. So yes, we unfortunately we're in an obese society that pushes eating. We have prepared food that's very high in calories, and I know that when I was a resident, I had people coming in from other countries, residents, and they were thin when they started. By the time they finished their residency, they were all obese like us, and they would say, "There's something with this food. Like
Yeah.
we seem to eat it, we gain
Yeah.
weight."
Definitely. Well, definitely. You know what? I think we should kind of get back to Basse. I know
Okay.
she kind of like review with us like protocols, I guess, early stages versus late stages. Basse, you want to kind of go over with us, like what were your protocols at least at the beginning of the pandemic, and how do they compare now that we're kind of like, I don't know where we should call ourselves in the pandemic right now, in the thick of it. But yes, what do you say, Basse?
Initially, there were no protocols because nobody knew what to do.
Right.
And they were throwing everything at patients. Anybody who came up with an idea, they tried it. There was, okay, we'll do all these, medicines that we had for a little while, we'll try that. Then they realized that nothing was working. And then it was kind of like, and then this is the really sad thing, because it was kind of like, I think a lot of people died initially because nobody knew what to do. And that's really sad, but I think that's what happens in something you've never dealt with before, because you just don't know what to do. And with the progression of, studies coming out from other countries, what people were doing, the researchers, and now it's like, okay, they've got a protocol. You come in, you're symptomatic, you get your convalescent plasma, you get one. What I've seen so far is that people typically get one dose, but there's some people who've gotten two, and I don't really understand why they would give two, but maybe they just felt that given the severity of what was going on, maybe the person needed a second dose. And then they'll start the remdesivir immediately. You get five doses once a day, and they start you on your dexamethasone, and it's IV. It's like, I believe, 6 milligrams, and I don't remember how often you get it, but you start off with that, and then it's a 10-day treatment. And what I've seen is that patients, their oxygenation requirements improve rapidly, because patients will come in and they'll be requiring so much oxygen, and then with the treatment, they've actually been able to wean them off and send them home in 5 days, 6 days. Some patients still go home with the oxygen, but for the most part, I've seen a great difference in how patients have, the outcomes of patients with the new protocol that they have in place. I have not seen a lot of hydrochloroquine being given. I have seen it for a few patients, but I think those patients probably either were on it for something else and just happened to be on it. But I'm not speaking with any authority on this. I'm just saying this is what I've seen in my experience when I review the charts. The hospital that I'm at, we don't do ECMO, so I don't know what the choices are for ECMO versus vent.
Right.
But typically, when I worked at Washington Hospital Center, patients on ECMO didn't typically do well. So I'm going to just stay away from that.
Yeah, I agree, Bosday. Patients on ECMO do well. It's very invasive, and generally, they reserve it for young patients.
Yeah. So that I haven't seen, so I can't speak to that. The socioeconomic disparity, I mean, that is evident everywhere. And I won't spend so much time on it, because you find that it's a complicated topic to deal with. The demographic in in Washington Hospital Center, Southern Maryland, and the hospital I was in Georgia, they're similar. So there was a high level of minorities coming in versus the for want of a better description, the Caucasian population, the minority population was just that much higher because it's the demographic that I've been in. So I can't speak to say like a place like Minnesota or somewhere else where the demographic is different. So I touched on the home management where, you know, families are living in such great fear that if this person who comes with COVID positive tests, whether they're infectious or not, is going to kill everybody. So nobody wants them. And the needs are, you know, they need a lot of the patients are mostly older who I've dealt with, and the debilitation from the virus itself is profound. And we end up sending a lot of people to rehab because they're just so debilitated from it. I'm not sure how much of it is that they might have been a little bit debilitated before, and this just kind of pushed them over the edge. But we especially in Georgia, we did a lot of skilled nursing home placements, and we're talking, my stint in Georgia was between April and June. So we were kind of like in the real thick of it, where we just really didn't know what to do and how to do it. So none of the facilities were taking COVID-19 patients. Now that we're here, we're actually treating a little better and we have better understanding. Facilities are now more willing to take them. It might also be because when they were not taking the patients, you know, they weren't making money, and it might now be an economic need. So they've kind of adjusted what they're doing to take patients so they can pay their bills. I don't know what the answer is. All I know is now it's a lot easier for me to place COVID-19 patients.
Well, definitely, there was a financial situation. And I think actually now, I think it's just been released. I think, isn't there higher payment now for patients who have COVID-19? I think that was passed recently. And
I would think that would make sense because they have, all the facilities have to, everybody, they're not cohorting COVID-19 patients.
Mm-hmm.
You know, everybody needs to go in a room by themselves.
Yeah.
Even if you have 2 COVID-19 positive patients, they're not putting them in the same room.
Right. I mean, it's interesting. So what are they doing over there? Because I'll tell you, the facilities out here, what they're doing, you know, so if they're taking patients, if it was a confirmed COVID-19, obviously, yes, they sequester them. They have a whole ward by themselves. They sequester them, single beds and all whatnot. But for other people who are not even COVID-19 positive, what they're doing though, there's this presumed protocol because, you know, they came from the hospital and it was high risk. So therefore they kind of quarantine them for 14 days. They test them coming in. They test them after the 14 days just to confirm that they got negative before they let them kind of join the general nursing home population. Is this similar to what's going on where you are?
Some of the facilities are requiring a COVID-19 test before they come.
Mm-hmm.
So we're doing the testing like within 24 hours before we discharge. So for example, if I've got somebody going home tomorrow, I need to have had my COVID-19 test done today.
Right.
And then they'll take them. And I'm not sure what they're doing in the facilities because once they leave me, I don't know what's being done.
Like, I don't want to.
Yeah, so I don't know what's being done in the facilities, and I have enough going on in my facility. I don't really want to know what's going on in yours, as long as I get my patient go out. But then I've had other facilities that, you know, will take them, and then they will treat them as potentially infectious and do their thing at their own place.
Mm-hmm.
I've also had, and this is something that really bothers me in my experience working, is that I would have patients who would come in and they would be negative, and they would put two negative patients in one room, and then one of them has to go for whatever procedure, and they test that one tests positive. So now the person who's been in the room with them,
right,
plus all the people who have been coming in, the clinical people, you know, wearing just a little paper mask and not gowning and gloving and doing the whole 9 yards, then everybody gets exposed. So what I've been doing in my personal practice as a case manager, even though I go on the floor to rounds, I basically treated everybody as infectious. So I don't go into any patient's rooms.
So I'm very curious. Wait a minute. Are they not doing universal precautions there? Because I'm like, everybody where I go, everyone's wearing a mask now.
Yeah, well, they're wearing the mask, but you're not wearing the shield and the and goggles and all of that. Because if your patient is deemed negative, why do you need to put the goggles and the face and the shield and everything else on?
But are they screening everyone beforehand to make sure they're negative? Because if you're not, then
they're not testing. No. That's what my point is. They're not testing everybody who's walking into the ED and being admitted. And my personal feeling as a clinician and a case manager is that if you're going to admit somebody to a hospital, you need to test everybody for COVID-19 if they're going to be admitted to your hospital, simply because you want a baseline.
Oh, absolutely. I mean, well, that's what they're doing here in New Jersey. So I'm actually kind of shocked that they're not doing that.
They're not doing it here. They're not doing it here in my hospital because, you know, I have had one patient who was really, really upset. He came in for an ambulatory procedure. They put him in a room with another ambulatory person. The second person tested positive, and this guy was really, really upset. He said, "You put me in a COVID-19 room. You and I was trying to discharge, and I was trying, so I got reamed out because I gave him COVID because my hospital." I mean, that is what I deal with as the case manager, discharge planner. You gave me COVID because you put me into. I said, but this is the first time talking to you. You've been here 15 days. But that's the perception, is that the hospital gave him COVID. The hospital exposed him. And that I have a problem with hospitals, when you are not thinking ahead about, especially all what we know now, that people can be COVID positive and asymptomatic.
Oh, well, right. Definitely. I think honestly, if any hospital, look, I'm not going to fault any hospital if they say they don't want to screen everybody through the door. Of course, I can understand. It is a daunting task, both policy-wise, procedure-wise, and economic-wise. However, I feel if you're not going to do that, then your alternatives is really everybody has to kind of be gowned in PPE.
Right, and you need to have single rooms for everybody.
Yeah, absolutely. You have to have everyone down to PPE, and everyone has to be single room. So it's kind of like, you know, you have to kind of pick your poison with it. But it cannot be that you're going to just kind of do sort of business as usual. No, because, you know, you don't know who is going to have this virus. And so it's either you treat it like everybody is probably positive, kind of like what Dr. Halasa is saying. Hey, everyone is probably positive coming in here, so we're going to treat you like you're probably.
And that's how I treat all the paid people that I've dealt with, because I have not had any patient contact since COVID-19 started. I've been working full time. I've been doing my discharge planning. Everything is done on the phone. All my documents that I have to get patients signed, I give it to the nurses and they take it into the patients. When they bring it back, I put my gloves on and I do whatever I have to do with the documents, and they go back into the plastic bag. So, I mean, I am very careful as a clinician in the front line. Mm-hmm. I take the precautions that I need to take. There's nothing that I'm doing as a case manager that requires me to actually be in contact with anybody.
So that proved by case that nurses are more exposed to the virus than doctors, right?
Yes.
No doubt about that.
Oh, yes. Yeah. Because they go in more frequently to the patient's room. So whereas the doctor goes in once for the day into the patient's room, the nurse is going in for a variety of reasons. So, you know, the frequency, the length of contact, I mean, that's, you know, infection control 101. You know, the more often you have contact with somebody, the higher your risk is for an infection.
So if I have a nurse, she's obese, do you think it's the right thing for her to continue her job, or we need to really isolate that obese nurse to stay at home, decrease the weight. Otherwise, if I put her in a job, she's the high risk of getting infected and get complicated and die. So that's what I'm trying to say, is that vulnerable people are the one needs to be isolated, are the one needs to be taken care. But if you are positive and healthy, you just wear the mask and social distance. I don't think the isolation will be the right thing for that. But I think the isolation is for think about it, 90% of the people in ICU who are being infected, they have underlying diseases, and most of the time they're obese. But of course, they may have other problems. So those are the patients, those are that people, they need to be isolated. I will not have a nurse obese working. I will definitely say, take care of your weight before you go to the job. Or patients diabetic and he's not taking his insulin and his sugar is high, and he says she's a nurse and she's dealing with the patients. If she got infected, she ended up with ICU.
Yeah, well, that is a real risk that nurses and any care clinical person takes when they decide whether they're going to go to work or if they're going to stay home. And it's personal decisions. Economics play a big part into that. I'm healthy. I don't have any medical conditions. I don't have any issues at all. But I still take my precautions because, I don't want to be sick. I don't want to get this virus that's going to, even if I get, say, a moderately severe disease and I have to be out of work for a little bit, I don't want that to impact my economic, because then I have to now dig into my savings to pay my bills. I've got to make a decision, how much exposure I'm going to take and how much risk I'm going to put myself under. And I think that's what every medical person has to do on an individual basis. How much risk am I willing to put myself under to do my job and pay my bills? That's a personal decision.
Right. Well, this has been a great conversation. And unfortunately, we have kind of passed the 8 p.m. mark. It was very lively. I think, this has been great. And I say we thank you for just bringing your wealth of experience here and just sharing with us all your knowledge that you've gained on the front line. So thank you so much for that. Definitely appreciate.
Thank you for having me.
Yeah, and I think next week I think we want to try to hit on reinfection, because that's been something that's been kind of making headlines of late. Reinfection and kind of like evaluating the plasma emergency use. What's the next steps on that? So hopefully we will be able to kind of cover that next week.
Yeah, and we will also be including some of the vaccine monoclonal, because we had some interesting discussion on the monoclonals, and so there's some new updates on that one. So that we will be covering next week, and also some of the FDA different tracks that the different partnership on vaccine is happening. That will also be. But we can take another minute or two if anybody has any questions. We can address that before we close. Okay, so I would say thank you for everybody for joining today, and I really appreciate it for joining. If you have any questions, I do have a slide that shows where you can reach out to us. It's inquiry@globexhealth.com. If you have any questions for any of the speakers from any of the sessions, we'll be able to get the answer to you. I'm looking forward to seeing you next week, and thank you, everybody. Thank you, Basti. Thank you, Dr. Grossman. Thank you, Dr. Okasanya, and also for Dr. Halasa and all the others who contributed today.
Thank you.
Thank you.